Great to be here. Thanks for the invitation to speak. This is going to be a little bit of an overlap with what Dr. Lee just spoke about, but actually a lot of points in this talk are going to resonate with Dr. Chopra's talk too. So these are my disclosures, none relevant. So we'll talk about the evidence for DVA just briefly and more about patient selection and technical criteria, selecting the right patient for this procedure, and then talk a little bit about the procedural steps, again, a little overlap with Dr. Lee. So this is a case presentation. We'll start with a 71-year-old guy who came to me about a year after he had a left TMA and then developed this non-healing left heel ulcer, diabetic, low EF, CK83. And prior to meeting him, he had been diagnosed with calcaneal osteomyelitis and underwent partial calcanectomy and was VAC'd and prolonged parenteral antibiotics. And despite all of those efforts, persistent non-healing, and was admitted to the hospital for consolidation of care and kind of planning with anticipation that he's going to need a below-the-knee amputation. But this guy is really motivated to salvage the limb, which I think is where the patients who are appropriate for DVA really start. Non-compressible ABIs, you can see the transcutaneous oximetry indicates poor baseline tissue oxygenation. And the angiographic findings for this particular patient confirmed reasonable femoral popliteal outflow. He did have a moderate lesion I indicated with a blue arrow there in the kind of the P3 segment of the popliteal artery. I had multiple attempts to open this TP trunk and try to restore flow to the hindfoot, and there was unfortunately just a really calcified dissection that both antegrade and retrograde could not be crossed. And you can see this patient actually has pretty reasonable perfusion to the dorsum of the foot, but of course that's not where the ulcer is, and consequently why he continues to have problem. So Dr. Chopra talked about, kind of what CLTI is and what our endpoints should be. And I think the goal of this procedure is, really making sure that we've exhausted all options, all conventional surgical and endovascular options. Many times these are patients with SAD, small artery disease, represented by the calcification seen as lateral foot projection. Ischemic ulceration of a functional limb. So this is not a procedure for somebody who's contractured and bedbound or somebody headed for palliative care, but somebody who hopes to use a functional limb. By no option, we mean that they've had failed surgical or endovascular revascularization with no additional conduits or reasonable expectations that additional treatments are going to be able to reperfuse the wound. So the treatment for my patient was really major amputation, for which he was admitted to the hospital for. They kind of tried chronic suppressive antibiotics, and he was not interested in hyperbaric oxygen treatment with a low EF, not a great option for him, or DVA. So just a little bit of alphabet soup here, but DVA, now that LymFlow has received FDA approval on the 12th, you may have recognized procedure as transcatheter arterialization of the deep veins. And I think of this a lot like TAVR. We throw around TAVR now pretty liberally to talk about percutaneous aortic valve replacement, but that's not how Elaine Cribier described the procedure in that 2002 Circ article. So TADV is kind of the unique LymFlow products to accomplish this procedure. We consider the other off-the-shelf, or also called off-label venous arterialization procedure, to use conventional and currently available products like the reentry devices, snares, valvulotomes, and covered stents. So the no-option CLTI patient is a DVA candidate. Really, it's a lack of a pedal target, as I've mentioned, with preserved iliac SFA and popliteal inflow into your graft. These patients cannot have an uncontrolled foot infection. That patient's probably best served with primary amputation if the infection cannot be adequately surgically treated. And then the target pedal veins have to be of adequate size. So all of these patients get screened with a vein mapping of the foot. And I think probably the most important thing is patients know what they're getting into and are up against. It is a very good procedure for patients who have no other option other than below-the-knee amputation, but they have to be motivated to limb salvage. They can't go into this half-hearted or half-informed about what is to come, and should be supported and compliant with follow-up. So not great for like a homeless patient, for example. So as Art it showed, really we're just rerouting physiology where the arteries are occluded and perfusing the capillary bed retrograde through venules. And it does take 3 to 6 weeks for this DVA circuit to mature. So the point about delaying any additional foot surgery is important after this procedure is done. I'm not going to go into the slides here too much on the data, but just to say that the heavily diabetic population with a lot of renal insufficiency, which we all recognize characterizes the population, with pretty reasonable amputation-free survival out to 12 months in the first U.S. attempt at this procedure using the lymph flow products. That data was presented by Dr. Clare and colleagues a couple years ago now. And then, of course, we just recently published the PROMISE-2 study, again, heavily diabetic population with a lot of CKD and met its primary endpoint with about 2/3 of the patients achieving amputation-free survival out to 6 months. This is probably the most important slide where, really the criteria is shared decision making and making sure that what you're about to embark on is right for the patient, that the DVA is for those who are motivated, socially supported, and compliant, as I've mentioned before, and that they're appropriately educated about the procedure. And I put this PROMISE-1 wound status over time graph, just showing the follow-up in months out to 2 years. And you can see, as we've been talking a lot about today, these wounds do not heal quickly. And about half of the wounds in PROMISE-1, which was a smaller study, were healed at about a year, and that was exactly what we found in PROMISE-2. So this is a procedure that works, but it is only through a lot of persistence and diligence. So these patients have to have follow-up care, transportation, they have to have their social needs met. If they're food insecure or don't have a ride, that's got to be sorted out before you do this procedure, because it's not fair or right for the patient to undergo this procedure without those things in place. Wound care, ID, podiatric care, all that needs to be in place before this procedure is done. Frankly, this procedure is the easiest part of caring for these patients. The technical criteria for DVA, really just the absence of a usable pedal artery, as I've mentioned, and that lateral plantar vein needs to be at least 3 millimeters to have an adequate place to land your stent. We're going to land the stent in the lateral plantar vein, which is this plantar plexus of venous return in the midfoot. And as you walk, this actually has a peristaltic mechanism to move blood up the leg, so it's a pretty good reservoir for arterial flow once we get it reversed and stented. So I usually start this with a venous axis in the foot. That can sometimes be the most challenging part of getting started on a DVA program, is just these veins are very prone to spasm. Ipsilateral arterial axis then, and creating that AV connection with valvulotomy of the posterior tibial veins, and then placing the covered stents to the ankle. Angioplasty of the outflow veins is really key. I got burned on my very first PROMISE-2 patient just with an inadequate angioplasty into the lateral plantar vein, which too has valves. And so you have to really be diligent about making sure that your angioplasty extends out into the midfoot and then achieving axis site hemostasis. This was my very first case where I screwed up the venous axis, caused the vein to spasm, couldn't get in. Then I had to use the medial marginal vein and go through the foot to eventually have a point to axis and get my lateral plantar venous sheath in. So it does take some time to kind of get used to the venous axis in the foot. It's about 2 centimeters deep in some patients. So you want to stick it once, and there's some tips and tricks to ensure success. Then after your venous axis in, usually antegrade axis is no problem. We throw the crossing catheter and wire in and snare it and pull it in through the foot, and then you're home free. And then the rest of the procedure is actually straightforward, and you can see the completion angiogram here with a good flow into the midfoot. But to the point, at the completion, here's kind of what you have at the axis site, and that's generally hemostasis achieved just with some manual compression. Antiplatelets, in my practice, usually dual antiplatelets for at least 3 months. I tend to leave them on till they heal. The expectations, forefoot ischemic pain is common, no wraps to the foot, and foot surgery needs to be delayed. Foot surgery must preserve the pedal plantar loop with no tourniquets during those subsequent surgeries. And again, just to reinforce that delayed wound healing. So we did this patient's DVA in March 10th. And so this was his pre-op picture prior to TMA. And, we actually left it open. And then, boy, the surgeon said, God, it looks really good. I think we can close it. And so against better judgment, we closed it. And then, we ended up having to open it again. So the point is you got to kind of follow the roadmap that's been outlaid. These patients need delayed surgery, and they got to heal by secondary intent. He went on to heal, but so we follow DVA grafts just like we do other grafts with volume flows. 150 to 250 is kind of our target. More than that, and you get steel. Less than that, and the graft is more likely to close. And those duplex ultrasounds are repeated monthly. The time to graft occlusions, in the publication by Dr. Clare, 6-month average graft lifespan, half of grafts underwent intervention, and most of those interventions were in the first 3 months. So they tend to go down early if they're going to go down. As you can see, back to my patient, had a nice result and healed over about 3.5 months, which is frankly pretty quick. So pain and swelling, if it's none or mild after the procedure, we tend to discharge them. If it's more significant, we have some maneuvers we can do, but sometimes it requires coiling to reduce the outflow. So I think of these DVA patients kind of with 3 different components: the graft, the wound, and the patient. So the graft needs to be followed, the wound needs to be cared for, properly offloaded, and properly treated by someone who is familiar. And then the patient really needs to be supported with nutritional support and health-related social needs. And these patients really need you to be their advocate and own them, follow them up. If they show up in an ER, they're going to get their leg amputated if people don't understand what a DVA is and what you've just done and how terrible the foot looks. So these patients need to have a hotline to your practice. So to conclude, criteria for DVA for no option CLTI includes clinical, anatomic, and psychosocial factors with shared decision-making. Pain and bleeding may complicate the post-DVA course, and patient selection, ultrasound surveillance, and clinical follow-up are really keys to success. Thank you.